Over to you.
Yeah, good afternoon, one and all. I have no financial interest in this presentation. So I'll be talking about pediatric cataract. So it includes a wide range of parameters to be discussed with and tips for everyone. So all white pupillary reflex is not cataract. We have to remember this. So anything white in the pupil area is definitely not cataract. What is most important is to rule out at younger age is retinoblastoma. It could be unilateral or bilateral. The other things that we have to keep in mind is the PHPV, Toxocara infections or toxoplasma, retinal detachment, and off late now picking up is ROP, and sometimes even coloboma can mimic a white reflex. Diagnosis is based on the duration or the timing at when the cataract is seen or onset. It could be congenital, developmental, or acquired. It could be unilateral or bilateral as seen in these pictures. And the typical type of cataract is the sutural cataract or the zonular or blue dot cataract in children as compared to the other types of cataract called nucleus sclerosis or mature cataract. We can also see mature cataract in children. Yet another area where we have to understand these cataracts and the lens abnormalities are the subluxated, as in case of Marfan syndrome, or microspherophakia in Weil-Marchesani, or subluxated with microspherophakia with aniridia. We have to remember WAGR syndrome, Alport syndrome, as in case of anterior polar cataracts. We have to get these children evaluated completely by a pediatrician. The causes, when we look at it, could be unilateral or bilateral. Unilateral is usually sporadic, and bilateral it could be autosomal dominant. Most important, we have to rule out metabolic conditions. It's worth a while to take an opinion from a pediatrician to understand the wide range of metabolic conditions. Infections, very routinely I do get the torch titers done both for IgG as well as IgM. This is very important because post-op inflammation can be very fatal, or it mimic like endophthalmitis. Nevertheless, we have to understand the various chromosomal anomalies, associated ocular anomalies or anterior segment dysgenesis, because the surgery becomes more complicated. The other thing is developmental delay. Children with developmental delay, they can be associated with cataract. Complicated cataracts are like uveitis or associated with retinitis pigmentosa. In 50% of the children, it is idiopathic. So you need to investigate. The necessity becomes more so in bilateral cases where we rule for metabolic condition, torch titer, and what important important thing in clinical practice is understanding the levels of homocysteine, because this poses a problem during general anesthesia. These children, if they have low homocysteine levels, we have to understand that these children can have thromboembolic phenomenon and we can lose the child. Urine for reducing substances and to rule out low waist syndrome. Uveitis, if it is associated with, we need to evaluate in detail. So management of pediatric cataract is more complex than adult cataracts. All of us know about it because it's a great challenge. Because the eyes are smaller, tissues are softer and elastic, and we cannot understand how to go about, especially the beginners. We have more pronounced post-op inflammation, as I mentioned, especially so if it's associated with torch titers being positive. A rapid PCO, and it will mimic as if there is cataract and you haven't done the surgery at all, because the pupillary area again will have white reflex. Most after doing all this is the visual rehabilitation, and amblyopia management is definitely a challenge for us. When in doubt, we should not defer examining these children under examination under short general anesthesia or even oral sedation. A dilated examination is a mandatory thing. We need to understand what is the corneal diameter, auto K or the K reading, A scan. AC depth is yet another important parameter for surgery purpose. Fundus examination, if not B scan, pupil dilatation gives a clue as to how to go about during the surgery, and status and the type of cataract, and also analyze what is the intraocular pressure. Usually we operate children above 1 month of age, because quite a risky thing to operate less than 1 month. Few considerations before taking up these children for surgery is whether it's congenital or developmental, because it gives a clue as to post-op visual development. visually significant or not, unilateral or bilateral, whether it's progressive or stationary, partial or incomplete, and most important, whether there's associated nystagmus or deviation that gives a clue to the post-op visual outcome. Now, coming to timing of surgery, if an opacity is more than 3 mm with visual axis involvement, unilateral or bilateral, irrespective of the type of cataract, and if it's associated with squint or nystagmus, or whether it is a simple cataract or a complicated, operate at the earliest. On the other hand, if the lens opacity is less than 3 mm, involving the anterior capsular area or subcapsular area, associated with systemic problem, and they are unfit for general anesthesia, it's better to delay the surgery. So during this interim period, what can we do is we can dilate the pupil with homoatropine 2% maybe once a day, and you can explain to the parents as well. So it keeps the pupil in mid dilated, and some vision development is taking place. Now coming to another important parameter is the IOL power calculation, which I'll be talking. The best way to rehabilitate these children is, after removal of cataract, is implanting an IOL, but nevertheless it's not possible all the time, especially if it's associated with anterior segment dysgenesis, small corneas and small eyes, and less than 2 years. So the most widely used formula is SRKT, however the best one would be offer Q. Now earlier we were following based on axial length. It was an arbitrary way of understanding what IOL power to be implanted. Now this is gone outdated, and we use the Adan et al. Formula. Less than 2 years we are undercorrecting by 20%. That is whatever you get on the A scan after calculation, you undercorrect by 20%. Between 2 to 8 years we undercorrect by 10%, and at 8 years we can put the same IOL power as we get in the A-scan report. But however, I differ slightly with this. Between 2 to 8 years, it's quite a wide range. So what I do is, between 2 to 5 years, I undercorrect by 15%, and 5 to 8 years, I undercorrect by 10%. However, our main aim for all the pediatric ophthalmologists to have a post-op hypermetropia. Of course, the child is older, we can go for emetropia. Now coming to few problems with early surgery and late surgery, let's see what it is. Definitely early surgery, we have difficulty in rehabilitating these children with IOL or glasses or contact lens, intense post-op inflammation and rapid after cataract, and there is increased rate of resurgery. On the other hand, if it's late, then these children can develop amblyopia, which can be refractory, or there can be an overall developmental delay in these children. There are two surgical approaches, pars plana and limbal is the most versatile technique, and pars plana, it is confined to or preferred for children who have anterior segment dysgenesis, small cornea, small eye, etc. Now let's see the technique per se. So the first most and important is getting the anterior axis. We definitely use sodium hyaluronate. Methyl cellulose will not be helpful for beginners. If it is a zonular cataract, just follow the margin of the cataract and use capsular forceps. It could be utrata forceps or microforceps or vitreous forceps. The mantra is grasp, release and regrasp. That's the important thing. Now coming to hydrodissection. Yeah, it's like any other cataract. It may not be as easy as in adults, but you can do hydrodissection with hydrodelineation, and it's in soft cataract. We can easily remove it. It's so soft, sometimes you can just visco express, but make sure that we don't collapse the chamber. Now coming to aspiration, on the left hand side you can see that the corneal diameter is slightly lesser, but nevertheless I am using IA probe to aspirate the cortex. Alternatively, we can use the Simcoe cannula as well, but the main thing is to maintain the chamber. No matter which technique you are using, maintain the chamber so that pupil doesn't constrict, and later the steps become difficult. We can also use the bimanual aspiration technique. For subincisional cortex, sometimes I use the Helon cannula and I go through the side port because the rexus size is smaller here. So it might be a little difficult in case you are not using the bimanual technique. You can use just the cannula and aspirate. Now coming to yet another technique is the tackling the posterior capsule. Here in this video I am showing the PPC which is being done using the capsule forceps again. You need to have a good red glow and the AC should be slightly shallower. Make a flap or a nick and then inject little bit of Helon beneath the nick or the capsular flap which you start. And then you can do the rexus like the anterior capsular rexus, but only thing it has to be smaller than the anterior capsular rexus because you need to place the IOL inside the bag. If it becomes bigger, then you can have a IOL drop. Now looking at the other part of tackling the after cataract is doing the vitrectomy for children less than 8 years. Sometimes if the child is having developmental delay and if you anticipate that this child may not cooperate for YAG capsulotomy, we need to do for these children vitrectomy. There are two techniques. One is going behind the IOL after you have placed the IOL. Some people routinely follow that, even I do that. You can do the vitrectomy behind the IOL after doing PPC. The PPC can be done with the cutter as well as manually. Manually you will get a more curvilinear rexus compared to the cutter. Or you can do vitrectomy first, do PPC as I have already done here. You do vitrectomy and then you can implant the IOL, whichever is comfortable. Of course, you have to keep in mind the size of the PPC. If it is too large, it is difficult to implant the lens afterwards. Now, as I said, 0 to 8 years, I do posterior capsulotomy, that it is PPC-CC or using a vitrector, and I do anterior vitrectomy. And 8 to 10 years, what to do? What are the different options? You leave them, if you think the child can cooperate for YAG cap, you can leave the PC intact. You don't have to do any vitrectomy. Or you do PPC, and you get a good size of the PPC, then you can think of doing optic capture, which is the gimbal's technique. The advantage of this technique is that the IOL will be well centered, and we have seen good children not having PCO later. Other thing is you can do anterior vitrectomy and implant the IOL in the bag. Now regarding to the IOL types, as I said, less than 2 years I am not implanting. Earlier I was implanting, and now again it's always changing. Monofocal is preferred, and PMMA IOLs are having long track record of safety, and they are doing very well if you do good vitrectomy and PPC. Foldable IOLs, of course, no second thought at all. But yet another parameter is the sizing of the IOL. Corneal diameter has to be measured, and 1.5 to 2 millimeter greater than the size is the IOL size that you can choose. Multifocal and toric IOLs, however, it can be preferred in older children. Now coming to the various types of IOLs that I have implanted are hydrophilic. It's not my preferred lens. But older children you can think of. This is my preferred. I have no financial interest. I like the IQ lenses the best because it releases so slowly that you can implant the IOL in the bag and you have no fear that the leading haptic will enter the PPC opening. After doing vitrectomy, it's very easy for the haptic to enter the PC opening and you can have a drop. It's very difficult to implant these lenses in the superior section. All these children undergo surgery superiorly. Now this is the rigid IOL, that's also good enough. And this is sensor 3-piece, suits many situations where you think you want to place the IOL in the sulcus. It's a good option. Now PI is done in every case. I do that. I've been doing that for past 20 years. Now in this video I want to show the optic capture actually. Yeah, done.
Thank you.
So just implant the IOL using 2 Simsky hook. You push behind the optic capture. This is optic capture what I am doing. Push the IOL behind the PPC opening. So this advantage is it gets well centered and no after cataract. So visual rehabilitation, as I said, is the most challenging, and amblyopia management is the most important thing, especially so in unilateral cases. Thank you very much.